Welcome to EOR Review, where we bring you audible versions of end-of-rotation exam questions for people on the go. In this episode of EOR Review, we're going to do 10 internal medicine PANCE-style questions that you can listen to when you're walking around, driving to your next rotation site, or studying for the PANCE. Let's begin. Question 1. A 33-year-old male presents to your clinic with a 1-year complaint of shaking. The patient states that he first noticed his hands shaking on the job, but attributed it to skipping breakfast that day. He states that it only happens when he is doing something and never when he is sitting. Strength is 5 out of 5 in all extremities, and sensation is intact on physical exam. Family history is negative for Parkinson's disease. He denies numbness, tingling, gait disturbances, memory change, blurry vision, and tremors at rest. You suspect the diagnosis of essential tremor. Which social or environmental factor is known to improve this condition? A. Hot showers. B. Cold temperatures. C. Alcohol consumption. Or D. Tobacco use. I'll give you a second to review. The correct answer is C. Alcohol consumption. Alcohol is a CNS depressant which affects how impulses are carried to the peripheral nervous system. The olivary nucleus hypothesis suggests that alcohol reduces the rhythmic patterns generated by the olivary nucleus that may contribute to tremor frequency. Hot showers are not recognized as a modifier of essential tremor, as well as tobacco use, and cold temperatures may actually worsen the tremor. Next question. A patient is being evaluated for medication management of Alzheimer's disease. The physician is considering both cholinesterase inhibitors and NMDA receptor agents. Which of the following medications is an NMDA receptor antagonist used in the treatment of Alzheimer's disease? A. Diazepam. B. Memantine. C. Tacron. Or D. Rivastigmine. I'll give you a second to review. The correct answer is memantine. Memantine is the NMDA receptor antagonist used in Alzheimer's treatment. The other medications listed are all cholinesterase inhibitors, which work well but by a different mechanism. Question number 3. A 60-year-old male presents with a 4-week history of muscle weakness. A week or two after testing positive for SARS-CoV-2, he started experiencing weakness in his legs that has since spread to his shoulders and face over the last couple of weeks. He also reports numbness in his hands and feet, causing him to stumble and drop things. Physical exam demonstrates normal vital signs, but decreased muscle strength and sensation in all extremities and diminished DTRs. What is the most likely diagnosis given the patient's presentation? A. Guillain-Barré syndrome. B. ALS. C. Parkinson's disease. Or D. B12 folate deficiency. I'll give you a second to review. The correct answer is A. Guillain-Barré syndrome. The etiology of GBS is unknown, but it typically follows an acute viral illness and progresses rapidly over the next 2 weeks. This ascending weakness pattern with diminished DTRs following a viral illness is classic for GBS. ALS presents with mixed UMN-LMN signs such as spasticity, increased DTRs, and fasciculations. Parkinson's presents with a shuffling gait, cogwheel rigidity, bradykinesia, and resting tremor. B12 folate deficiencies have a slower onset, are associated with megaplastic anemia, and can cause things like numbness and tingling in the hands and feet. Next question. An 18-year-old female presents with a chief complaint of rapid heart rate lasting 20 minutes. For the last few weeks, she has had intermittent episodes of tachycardia lasting 15 to 30 minutes apiece. She never loses consciousness, but sometimes gets lightheaded and feels short of breath. EKG shows a heart rate of 150, no P waves, and a narrow QRS complexes. What medication is indicated if vagal maneuvers fail to relieve her symptoms? A. Atropine. B. Epinephrine. C. Dobutamine. Or D. Adenosine. I'll give you a second to review. The correct answer is D. Adenosine. The patient's EKG findings are consistent with SVT, or supraventricular tachycardia. Adenosine is the first-line pharmacologic treatment when vagal maneuvers fail. It works by briefly blocking AV node conduction. Atropine is used for symptomatic bradycardia, but not tachycardia. Epinephrine would only worsen the patient's situation. It is often used in cardiac arrest as part of your ACLS protocol. And dobutamine is an ionotrope for heart failure, not SVT management. Next question. The same 18-year-old female from the previous question now presents with the same symptomology. However, this time the ECG reveals a wide complex tachycardia with delta waves. Which of the following would be the appropriate therapy? A. Procainamide, B. Beta blockers, C. Epinephrine, or D. Dobutamine? I'll give you a second to review. The correct answer is A. Procainamide. The patient has antidromic reentrant tachycardia, or WPW, also known as Wolff-Parkinson's Y. The presence of a wide complex QRS and a delta wave suggest reentrant tachycardia, which precludes the use of typically used agents like verapamil, adenosine, or beta blockers. Procainamide is the appropriate choice. Beta blockers are contraindicated in reentrant tachycardia. Epinephrine is not indicated for this type of arrhythmia. Dobutamine is an ionotrope, not an antiarrhythmic agent. Question number 6. A 50-year-old male smoker presents for evaluation of cardiovascular risk. Lipid panel results are provided for your consideration of statin therapy. A. Total cholesterol of 230, HDL of 45, and LDL of 100. Option B. Total cholesterol of 250, HDL of 75, and LDL of 90. Option C, total cholesterol of 230, HDL of 40, LDL of 190. Option D, total cholesterol of 201, HDL of 50, and LDL of 110. I'll give you a second to review. The correct answer is C. The patient has hyperlipidemia, and because the patient has an LDL of 190, it is recommended that a high-intensity statin be started. The other values would require calculating the ASCVD risk to determine eligibility and potential benefits of statin therapy. Question number 7. A 70-year-old male on warfarin for AFib presents with acute onset severe diffuse abdominal pain that is worse after eating. He reports bloody diarrhea after a meal. Abdominal exam demonstrates diffuse tenderness with mild pressure. Vital signs include a BP of 160/90, pulse of 110, respiratory rate of 20, temperature of 98.6, and SpO2 of 98%. You decide to get an abdominal x-ray, which shows thumbprinting of the right colon. What is the most likely diagnosis? A. Appendicitis, B. Mesenteric ischemia, C. Ulcerative colitis, or D. Volvulus? I'll give you a second to review. The correct answer is B. Mesenteric ischemia. Patients with AFib are at risk of embolic ischemia. Severe abdominal pain disproportionate to the exam is the hallmark of mesenteric ischemia. The thumbprinting sign on X-ray is pathognomonic. Appendicitis typically presents with periumbilical pain that migrates to the right lower quadrant. Ulcerative colitis demonstrates, or rather presents with, left lower quadrant pain. Onset is typically between 30 and 40, and tenderness on exam would be expected. Volvulus is more commonly found in young children and the elderly who sometimes develop sigmoid volvulus. Question number 8. 30-year-old male with a history of IV drug use is brought to the ED with fever, chills, and chest pain for several weeks. The patient appears ill with a fever of 101.4. Physical exam demonstrates lesions on the feet and splinter hemorrhages of the fingernails. Which of the following murmurs is most commonly seen in IV drug use endocarditis? A. Aortic stenosis, B. Mitral regurgitation, C. Pulmonic stenosis, or D. Tricuspid regurgitation? I'll give you a second to review. The correct answer is D. Tricuspid regurgitation. Patients with infective endocarditis secondary to IV drug use most often presents with tricuspid regurgitation, which is best heard at the fourth intercostal space along the left lower sternal border. Aortic stenosis is not a typical valve affected in IV drug use endocarditis. Pulmonic stenosis is rare and not usually associated with IV drug use endocarditis. And mitral regurgitation is more common in non-IV drug use endocarditis. Question number 9. The same 30-year-old male with IV drug use and infective endocarditis is being further evaluated. Blood cultures have been drawn, and the team is considering empiric antibiotic therapy. Which organism is most often associated with IV drug use infective endocarditis? A. Staph aureus, B. Pseudomonas, C. Strep viridans, Or D, Aspergillus? I will give you a second to review. The correct answer is A, Staph aureus. Staphylococcus aureus is the most common causative organism in infective endocarditis associated with IV drug use. It is an aggressive pathogen that can rapidly destroy valve tissue, often acquired through needle sticks, as Staph aureus is often found on the skin. Pseudomonas is less common and can occur, but is not the number one organism associated. Strep viridans is more common in non-IV drug use endocarditis, and Aspergillus is a fungal endocarditis, which is rare, and seen in those who are immunocompromised. Question number 10. A 65-year-old male presents to the ED with a persistent headache for 2 days. He denies trauma or history of headaches. Past medical history is significant for an MI 3 years ago, hypertension on lisinopril 20 milligrams, and depression. He admits he did not refill his medication for 3 days. He also noticed dark urine recently. Vital signs show a blood pressure of 185 over 110 and a pulse of 95. Labs show a BUN of 30 and creatinine of 3.5. What should be done to manage this patient? A. Administer clonidine 0.1 milligrams and order a stat CT. B. Admit the patient for evaluation and blood pressure control. C. Administer nitroglycerin and collect a CBC. Or D. Discharge on the Betalol 200 milligrams by mouth with close PCP follow-up. I'll give you a second to review. The correct answer is B. Admit the patient for evaluation and blood pressure control. This question prompt should make you think that the patient is in hypertensive urgency, as is evidenced by the presence of AKI. The patient needs to be admitted so that further management can be undertaken, and discharge would be unsafe given the AKI. Clonidine is used for hypertensive urgency, not emergency with AKI. Nitroglycerin alone is not effective as a sole agent, and discharge on labetalol would be unsafe. The patient has an AKI requiring inpatient care. There's evidence of end organ damage because of the elevated BUN and creatinine, which should be the thing that sets you off down the hypertensive emergency pathway. Thank you for listening to this episode of VOR Review. Stay close, because we're going to have another episode with infectious disease questions. Thank you.